Hello and good afternoon, everybody. My name is Fatemeh Seyednasrollah, and from TYT Dream Challenge Group, University of Turku, Finland. And I'm going to present our model in prediction of Docetaxel adverse event. But so what is this talk about? I will be focusing on sub-challenge 2, which was introduced to you in advance. And just I wanted to mention that in patients with metastatic castration-resistant prostate cancer, the situation becomes like this, that the disease will be progressed despite the androgen blockade. So at this point, the treatment strategies will become mostly palliative rather than curative. So the available strategies are the palliative chemotherapy like docetaxel or the palliative radiotherapy. And there are also these next generation hormonal therapies, which I assume they were not available at the time that this data was collecting. The aim of the, or what is interesting for the physicians is they want to know that who are not the beneficial patients and who wouldn't really benefit from docetaxel. And what we did here, we just utilized the gradient boosting technique to predict these patients who will be at a high risk of developing adverse event within 3 months. So I mentioned that the treatment will be mostly palliative. So docetaxel has been shown that it can affect and it can increase the overall survival significantly. But on the other hand, I think Jim was also mentioning that it is a toxic drug, so many people will be mostly suffering from this rather than benefiting from it, and it can bring, for instance, neutropenia. And then, if it's palliative, what is the point of using that? So, early prediction of discontinuation is very important at this point. The experimental design were already explained, so there was also for the sub-challenge 2, there were the same data. So these 3 training data sets and then 1 validation data set. We had the preliminary tables, and they were properly integrated into core table, and we had to just decide if the patient will develop adverse event or is possible to complete the treatment within, of course, 3 months. I will focus on laboratory table because at the end we realized that the laboratory variables had the most relative influence on the final model, and I will have 1 slide for the other tables. So the heat map over here just simply shows you the percentage of availability of the data. So if it's red, it's 100% of the data is available, and the blue are the missing values. So for instance, even here you can see that the this ASCENT2 that Daniel was also mentioning, it is kind of an outlier even in the point of availability of the data, and then the AstraZeneca was very much more close to the other 2 other data sets. So we decided to first of all filter out the lab values. Over here on the rows you can see the lab values, and the columns are the data sets. So we decided to first of all filter out the laboratory tests that are not available in the AstraZeneca. And then second, we also filtered out those lab values that were missing from 2002 out of 3rd of the data, and by data I mean the training data. And then we also filtered out the highly collinear variables. So for instance, we realized that the neutrophil and then the white blood cells are highly correlated to each other. So we decided to keep the neutrophil and just discard white blood cell. And it was the same for albumin and hemoglobin. Albumin was available in the reference model, the Halabi model, but we decided to keep hemoglobin because it was available for almost all the data sets. And at the end, we filtered out some irrelevant lab tests that suggested with our clinical members. So we mostly filtered rather than imputation, because we didn't get very good results with imputation for this sub-challenge. We also did some scaling for the laboratory values, because they were from different data sets, and they had this different range of minimum and maximum for the normal in their kits, I expect. So we scaled them based on the maximum and minimum references. So at the end, the normal range for a specific lab value was between -1 and +1, and then other measurements upper or lower than this was counted as abnormal measurement. And then also we made the log transformations and truncations for highly skewed tests. So it was all for the laboratory test table, and I have one slide for the other tables. So I want to show you the exactly the same figure for the lesion table. So again, you can see here that the availability of the data is the kind of, as Daniel also mentioned, it was redundant for the bone. So all of the patients in the validation data set has the bone metastasis, so it couldn't be a good predictor for having these lesions as a feature. And also we realized that there are some missingness due to the data provider. So what we decided to do, rather than imputation, we decided to define a lesion risk score, and we just simply added all the available lesions for each of the patients. So we got the arithmetic sum of the lesion sites, and we got only one score for each of the patients for the lesions. And we followed the same strategy for other tables. I mean, prior medication, medical history, and prior surgeries or procedures. So all of them were kind of transformed to unique risk score. So we were ready to kind of formulate the problem. So we had the clinical features like age, BMI, and then we had the laboratory test modified as I explained, and then we had the scores for each of the patients. So we already have kind of reduced the dimension of the input data, and we hope to get less overfitting problem and so on. So the question was, again, predicting treatment discontinuation. We had two different possible distribution assumptions. We could see and formulate the problem as a Bernoulli distribution, so discontinuation as 1 and then continuation as 0. Or we could model it as a survival model and having, for instance, Cox proportional hazard model as the penalizing. So these two assumptions were for the output distribution, and then we checked SVM, GLMNet, and gradient boosting methods. And you can see that the winners among our candidates are already in red, so we got better results with this. So gradient boosting model, they are the ensemble learners. I think you should be all familiar with them. And again, here is the wisdom of crowd. And Daniel was mentioning that it's interesting that we have been using ensembles, and then the dream main idea is also wisdom of crowd. So it was a nice coincidence. So we are trying to merge several big predictors to a powerful final learner, and most of the time the basic learner in these methods are the classification trees, although we can have other methods as well, and maybe the common examples are bagging and boosting. To my knowledge, boosting should be similar to bagging, but it's a kind of more smarter way of averaging the classification trees. So it starts with initializing a simple predictor and calculate its residual errors, and then you will start a loop. So you will iteratively produce the boosts or the median predictors, and at each step you are trying to reduce the errors of the previous predictor in your analysis. So at the end, you will end up in several boosts or medium predictors, and then you will weight them based on the stage. So for instance, the simple way is that the last boost you had, you should have had better performance, so it can be weighted as higher. And then at the end, you can decide about the majority of the votes based on the boosts. So we basically use the GBM package in R for our analysis, and use the survival package also for the formulating the outcome. So the event was this discontinuation of the docetaxel, and then the time was days to adverse event. And of course, cross-validation always for avoiding overfitting and generalization of the model. I also have the Kaplan-Meier curve here for different input data sets. As you can see here, it's the same as previous figures, both in my presentation and Daniel's. You can see that RSG2 is clearly performing different. So in RSG2, patients reached their lowest probability, survival probability, which is discontinuation of docetaxel here, very drastically comparing to the Celgene and EFC data set. And then this black line here shows the 3 months. So we had to kind of predict the discontinuation within three months. And then whatever you can see on the right will be right censoring and just discarding. So there could be different strategies for this. Actually, we tried averaging of the different models for different data sets, and it worked for sub-challenge 1, but it didn't work for sub-challenge 2. We also omit RSG2, but it didn't work for sub-challenge 2. So still open what to do with that to get better performance. So in the final, the pre-selected features were, first of all, the laboratory test features. You can see them all here. And then the modification we have done over them. And then there were 6 other features, ECOG, ANALGA-6, and the scores for the lesion, medical history, and diseases, and period surgeries we had. And so you just an example that how the data look like. So for instance, you can see here that for the neutrophils, we had the minus values as well, and you know that if they are over -1, then it's still normal, and then the abnormals are more than +1 or lower than -1. And then this is the outcome table. So you have for instance, the discontinuation is equal to 1 if the reason of the discontinuation is adverse event or possible adverse event, and then the date to discontinuation should be less than 90 days or 3 months. And here is just one slide about the results. So our team were the second top performer in this sub-challenge 2. And if you look at the area under the precision recall curve, you can see us as the red point over here. We were about close to 90% accuracy, and I think because we are mostly interested in the positive cases here in discontinuation of docetaxel, so it was a good idea of using area under the precision recall curve rather than the area under the curve. And then this is one figure from the GBM package, and you can see the relative influences of the selected variables. So as I told you earlier, all the laboratory test variables were among the highest relative influence variables, and then we have the scores over here, and then the least important or least relative influential variable was ANALGA-6, similar to sub-challenge 1. And yeah, I just want, and there is one slide so at the top you can see our computational biomedicine group. We are a group of bioinformaticians, mostly work with high throughput data analysis, and it was our kind of first experiment with the clinical data. And we are working on cancer and type 1 diabetes, of course. And then here in the bottom, you can see our TYT Dream Challenge group. So me and Mehrad mostly did the analysis, and Laura is and the middle is the group director. And on the right, you can see our clinical members, oncologists from Turku University Hospital. And just thank you for your attention, and thanks from the organizers for this nice challenge. Yeah.
We have time for a few questions. Anybody? So, go ahead, Brian.
So this is sort of a meta question that might even go towards all the participants, which is the organizers knew that the ASCENT trial was a little bit different from the other ones. I mean, it wasn't a total surprise, but it's coming up here, you know, in each one of the talks. And I'm curious from the participants' perspective, is that something good to throw into a challenge? Is it good to have those sort of anomalies that you try and find through the course of the challenge, or are participants more interested in sort of a clean experience where you know, it's more model-based as opposed to, you know, feature selection or figuring out what data is most informative? Do you have a perspective on that? Yeah.
To my understanding, you cannot really say something about it before having the real data set. I mean, not the clinical trials, but the real data set. But yes, I think it can help because it will induce the heterogeneity into the input data, so could help. To my knowledge, yeah.
Actually, I had a kind of a follow-up on that. So you used the ASCENT2 in your model?
Sorry.
In your final model? Okay. Did you have a question?
I was just going to comment on the last question.
Oh, I'll go over there.
Actually, the question that was just raised kind of reminded me of the question I wanted to ask at the end of the last talk, which was if your modeling strategy would have changed or been any different if you hadn't had access to the covariate information for the AstraZeneca trial. And that also kind of relates to the ACCENT trial, because with both, you can find out that the ACCENT's very different from the other three. Yes. And in that sense, kind of game the system. Yes. And develop a model that may predict very well on the AstraZeneca. Yes. But there's the question of generalizability. If the point of all of this is to develop a generalizable model, how does that relate to how you would approach the challenge?
Yeah, actually, that's true, because, so for instance, we had this leaderboards for the sub-challenge 1, and we realized that we have a very good accuracy in the training data, but when we submitted to the leaderboard, then the accuracy was kind of going down drastically. So there was two assumptions. So if this validation data totally different from the training data, or is the model very, I mean, is the final model highly overfitted? So of course, we couldn't know about the validation data set, but what we did, we did the cross-validation within the studies. So, I mean, leaving out one study and then training the model and then validation on the leave-out study. And that helped to kind of pre-selection of the features. So when we did the pre-selection features over the cross-validation, we had better accuracy, but still I'm not sure if it's the validation data set or not.
Okay. I actually have a follow-up question to what Brian was talking about. It's actually great to see everybody use the longitudinal tables, which is my secret wish from the very beginning. But I can say right now I had a long debate with myself whether we should include ASCENT2 or not for the challenge, because my perspective, it's actually not from a follow-up time. It's more on missing information, because that trial was conducted quite differently, and it was stopped abruptly. So a lot of the lab are not captured, and we see missing on here. We see their data structure is quite different. I had to do a lot of background work to at least let it have enough information to even go on.
Yes.
But at the end, we decided to include that anyway, just because there's something about us, that trial that I want to see how people would react to that. So, and I do think that the fact that FIM didn't use it, you can say it gamed the system, but then another way you can also say that it's always biased. Whoever we've seen prognostic models out there, all of them are based on existing trials that they use. It's all going to be biased based on what they built their training model on. However, like the last comment saying that there's a real world out there. If you wanted to validate that model across, you have to have a little bit more generalized model to validate robustly across different data sets. However, the truth is, even if a cell gene and the data set EFC is from Sanofi are also very different. Yes. And it's actually, that to me, it proves somewhat of ensemble model might work. And ideal situation, if you have a big enough training data set, your validation would do a lot better. And across different trials, if you do multiple ensemble from different trials, even the Halabi model probably will improve their performance in validation. But thank you for the effort.
Actually, it's not related to this sub-challenge, but for the first sub-challenge, we didn't get better accuracy with omitting the ASCN2, but we got better accuracy when we averaged the models, so separate models for separate training data set and getting the average score for each patient. So I'm not saying that it's not useful, I just...
Yeah.
Okay, so
actually, sorry.
We do have to move on, so
okay.
thanks.